Pancreaticobiliary quick hits. Today's learning objectives include an approach to elevated liver enzymes, an overview of pancreatic diseases, biliary diseases, and when an ERCP is indicated. When a patient presents with elevated liver enzymes, the first step is to look at the pattern of enzyme elevation. Here we see whether enzyme elevation is predominantly a hepatocellular pattern, meaning that there is a greater AST or ALT elevation when compared to bilirubin and alkaline phosphatase. Or is the pattern cholestatic, meaning that there is a predominantly elevated alkaline phosphatase and bilirubin when compared to the AST and ALT. If the pattern presented is hepatocellular, we then break it down by the degree of elevation into severe, which is an ALT greater than 15 times the upper limit of normal, moderate, which is an ALT 5 to 15 times greater the upper limit of normal, or mild, when an ALT is less than 5 times greater than the upper limit of normal. You can see listed below each the different causes for the degree of enzyme elevation. If the pattern presented is cholestatic, we then look at imaging to help guide us as to cause of the enzyme elevation. We look at either abdominal ultrasound, CT, abdomen pelvis, if there's a dilation in the bile ducts versus not. Once again, you can see listed below the different causes for enzyme elevation in both normal versus dilated bile ducts. When a patient presents with concerns for pancreatitis, we break it down into acute versus chronic pancreatitis. Acute pancreatitis is diagnosed when 2 of 3 criteria are met. The 3 criteria include a patient presenting with sudden and severe epigastric pain. They have serology indicative of a lipase or amylase that is 3 times the upper limit of normal. And they have typical findings on imaging suggestive of pancreatitis, which include focal or diffuse enlargement of the pancreas, irregular contours, increased enhancement, or surrounding tissue staining. Chronic pancreatitis, on the other hand, is diagnosed when the patient is having fluctuating abdominal pain over a longer period of time. These patients do not always have an elevated lipase or amylase level, and actually generally they're normal. Additionally, imaging is more suggestive of a chronic process with findings of calcifications or atrophy on imaging. Causes of pancreatitis include medications, alcohol, hereditary or metabolic causes, and pancreatitis can also be idiopathic. Once the diagnosis of acute pancreatitis is made, initial treatment is goal-directed fluid resuscitation, as well as nutritional support with enteral nutrition, as it significantly reduces mortality rate compared to parenteral feeding. There are newer studies published that suggest that enteral feeding should start within the first 24 hours of hospital admission. In cases where there is a concern for cholangitis, ERCP is also recommended. If the patient develops findings of necrotizing pancreatitis, intervention is generally delayed until the phase of walled-off necrosis is seen. To prevent recurrence of pancreatitis, generally we encourage patients to remove the offending agent, whether it is alcohol or medications. If it's deemed idiopathic pancreatitis, a patient should undergo repeat abdominal ultrasound or endoscopic ultrasound in several weeks after the resolution of pancreatitis to ensure no underlying anatomic cause, such as pancreatic disease or a mass that is causing the pancreatitis. If patients have pancreatitis due to gallstones, patients should also undergo cholecystectomy during that admission. If they present with severe pancreatitis, they should undergo cholecystectomy at least 6 weeks after. Biliary diseases consist of gallstone diseases such as cholecystitis, cholangitis, cholecystitis, and acute gallstone pancreatitis. Malignancy is also consistent of biliary cancers, pancreatic cancers, metastatic disease. Benign biliary diseases include autoimmune cholangiopathy, benign strictures, and sphincter of Oddi dysfunction / papillary stenosis. Postoperative causes for biliary diseases include biliary leaks, which usually occur shortly after transplant, or anastomotic strictures, which occur later on after the transplant period, or other strictures from surgical procedures such as a Whipple. Gallstone disease includes symptomatic gallstones in which patients present with biliary colic and normal LFTs. Patients can also present with cholecystitis, which is when they develop pain, fever, and increased white blood cell count, and LFTs that are either normal or increased. Choledocholithiasis is when there is a stone lodged within the bile duct, and these patients can sometimes present with or without pain. Sometimes they don't even have a fever, but they do have the increased LFTs, and sometimes will have a normal white blood cell count. Cholangitis can also present with pain, fever, and increased white blood cell count, hypotension as they present septic, and altered mental status. Gallstone pancreatitis, generally patients present with pain. Normally they do not have a fever, but they do have an increased white blood cell count as well as increased lipase and increased liver enzymes. When patients present with cholecystitis, generally surgery is involved, and they look at the patient's different comorbidities at that time to determine their risk for surgery, whether they are fit or whether they should be declined for surgery at that time and be treated through their cholecystitis with antibiotics. Here is an algorithm in which you helps determine whether certain patients are fit for surgery during that admission versus at a later period. Cholangitis management includes resuscitation with IV fluids, empiric antibiotics. If the patients are hemodynamically stable, we generally recommend ERCP within 24 hours for drainage. And if they are unstable, generally these patients are the ones in the ICU. We consult our colleagues within interventional radiology for a percutaneous biliary drain. When suspecting a common bile duct stone, diagnostic tests that can be performed include a transabdominal ultrasound. This is good to detect gallstones as well as look for duct dilation. Generally, we say a common bile duct greater than 10 millimeters is a strong indirect predictor of a common bile duct stone. Patients can also undergo MRCP, which is great because no contrast is needed to evaluate the biliary tract for any stones or ductal anatomy. With contrast, we can evaluate for masses, lymph nodes, vascularity, and pancreatic parenchyma. An endoscopic ultrasound can also be performed, an intra-op cholangiogram, or a CT abdomen. Therapeutic procedures for choledocholithiasis include an ERCP to remove the debris within the duct or the stones, or an intra-op CBD stone removal. When is an ERCP indicated? It is indicated in patients with ascending cholangitis, generally within 24 hours of presentation. In patients with acute pancreatitis, only if they have cholangitis or concern for persistent biliary obstruction from stones, such as persistent jaundice or elevated bilirubin. If they have an elevated bilirubin greater than 4 or increasing liver enzymes in appropriate contexts, these patients will go to ERCP. If they have obstructive jaundice or post-surgical bile leak. Here I have provided an algorithm of the different biliary conditions and the different management strategies for each condition, including biliary colic, acute cholecystitis, choledocholithiasis, and gallstone pancreatitis. In summary, we have reviewed an approach to evaluating elevated liver enzymes, looking at whether the pattern is hepatocellular or cholestatic. We have reviewed acute and chronic pancreatitis and ways to prevent recurrence. In patients with a cholestatic pattern, we have reviewed different diagnostic testing, including abdominal ultrasound, MRCP, or CT abdomen for further evaluation of the enzyme elevation. And we have reviewed the indications for ERCP, including cholangitis and obstructive jaundice.